Hi, listeners.
Hello. Welcome to the MedInsights Unleashed podcast
With your hosts,
Z.
and John. Hi, MedInsights Unleashed listeners. Wishing you all a fantastic and successful 2026. And as always, I'd like to thank you for all your support. In previous episode, we discussed how degenerative disc disease can contribute to chronic back pain. Today, we're continuing on the conversation with a focus on the patients with more advanced pathology where surgical intervention becomes part of our discussion. I'm very pleased to be joined by Dr. Rohan Lall, a neurosurgeon affiliated with mHealth Fairview University of Minnesota healthcare system. Dr. Lall specializes in brain surgery, robotic and invasive spine surgery for patients with chronic back pain. In addition to his clinical practice, Dr. Lall serves as the Chief Medical Officer of Cinefuse and was the lead investigator of the Cinefuse Early Proof of Concept trial, which explored the electrically enhanced e-TLIF procedure for patients with advanced chronic back pain. For the listeners who may not be familiar with the term e-TLIF, the E stands for electrical nerve stimulation. The TLIF refers to transforaminal lumbar interbody fusion. This procedure combines standard spinal stabilization with targeted electrical nerve stimulation, the goal being to address both the mechanical instability of the spine and to treat the pain signaling pathways within the spine. Dr. Lall, thank you for joining us. Could you please start by briefly introducing yourself and your clinical focus?
Yes, thanks, John, for having me. Appreciate being on with you and having this great conversation. Yes, as you mentioned, my name is Dr. Rohan Lall. I'm a neurosurgeon based in the Twin Cities here in Minnesota, associated with a large complex medical center called mHealth Fairview, which is part of the University of Minnesota system. I am a neurosurgeon, which means that my practice is divided between brain surgery and spine surgery. I probably do a bit more spine surgery overall than brain surgery. So a lot of times what that entails is taking in new patients, evaluating them, looking at imaging, hearing their stories, looking at what types of past interventions, whether it be non-surgical things such as physical therapy or injections and medications that they've tried, evaluating what their symptoms and their level of current disability is with their current pathology going on, and then looking at the imaging that they have and trying to identify really what's driving the symptoms and difficulties that they're having. Armed with all that information, we try to develop a holistic plan for any given patient as to what is the right intervention to potentially try to help them out, whether that's not surgery, is surgery, or whatnot. And by the nature of it, certainly if you're seeing a neurosurgeon, many times you have probably pretty advanced problems on imaging and a high level of symptoms and disability. And so many of those patients that we see ultimately do end up needing some kind of pretty significant intervention.
So the question that I first have is from our previous discussion that we had with hydrogel, which is injected into the annulus. So what is the difference between the early phase where we're looking at hydrogel injection versus those patients where would be suitable for e-TLIF?
So when we are younger, right, when we're teenagers or in development, the spine is made of numerous individual segments, these vertebrae, and between them, there are the discs, and the discs have a hard outer shell, which we call the annulus, and inside they have a filling, which is called the nucleus pulposus. In the back of the vertebra, there are facet joints, which allow articulation between any given two vertebrae. So the L4 and the L5 vertebra have in the front an L4-5 disc, which is the interface between them. And in the back, they have facet joints, which are where little bits of cartilage and processes of the bone, which allow for motion. So about 50% of the strength of the interface between two vertebrae is in the disc, and then 25% is in each facet joint in the back. The central canal is a ring which sits in the middle, and that's where all the nerves run. And so ultimately, one thing that can happen to people as they get older is their nucleus pulposus, that pulp of the disc, can wear out. And so the vertebra can kind of collapse upon each other, and you can have sort of a bone on bone situation. And as those bones rub on each other, that can be a very severe source of axial back pain. So that's aching pain in the back. So that's one type of degeneration that we get as we get older in the back. But there are many other types that can happen as well. One other type would be overgrowth of those facet joints and arthritis in those joints, the same way you could get arthritis in your knee joint or your hip joint. So there's also ligamentous structures which surround the nerves. And sometimes as we get progressive arthritis in the back, those ligamentous tissues can become more overgrown as well, leading to pressure on the nerves and ultimately nerve pain. So disc degeneration is one type of arthritic degeneration of the back, but there are other types of arthritic degeneration, such as buildup of tissue causing stenosis, overgrown facet joints, and vertebral misalignments, and sort of other problems.
So when you're talking about overgrown facet joints, are you talking about the bony spurs, or is that something separate too?
Bony spurs can come either from the facet joint or they can come from the disc as the disc degenerates. A lot of times bony spurs are the result of the body's aberrant mechanisms of trying to heal something. A lot of spinal issues, or really arthritic issues, are your body is identifying that a tissue is weakening and it is trying to repair it, but its repair processes are actually damaging or aberrant in terms of the way that it is able to fix the tissue. So in its effect, for example, with a bone spur, the body may think something is broken because of the arthritis or degeneration in there, and it's trying to heal a break. But in the process of healing something that isn't broken, it actually just creates an overgrowth of bone that is pathologic and may, for example, push on a nerve.
When we're talking about hydrogel, then we're talking about sort of like pumping up the tire, right? So you inject it into the annulus, and then under fluoroscopy, you actually see the level of what you're going to do. Then you withdraw the needle, and then it seals itself. That's the principle between it, and they're doing a randomized phase 3 trial to further investigate that. When you're doing your e-TLIF procedures, you're actually using rods, screws. Can you explain the process?
Our procedure would be, I think, in general, for many patients who probably have substantially more advanced problems than potentially like a hydrogel type procedure. So without, being really involved in their company, by and large, most of those kinds of products conceptually would be, to your point, trying to, if you've got a bone-on-bone situation, can we regenerate the disc? Can we recreate that height and get the bone off the bone? And can we do that in a minimally invasive fashion? For our procedure, for the e-TLIF, you'd be talking about patients where, not only are they bone on bone, but the vertebra may be slipped 25% forward or to the side. The joints may be extremely overgrown, where the facet joints are now 3-4 times the normal size of the joints. The ligaments may be so overgrown that they are basically completely choking the nerves, almost like a 99% blockage of the nerves. And the patient may be at such a desperate state of disability where, you've got someone who at this point can't even walk and do groceries. They can't walk and get their mail. Maybe they're almost getting wheelchair bound. So patients who are at that really advanced end stage and who have these more advanced pathologies and degeneration need a more substantial procedure to repair that.
When we're looking at a spinal injury and disease, we're looking at about 80% of patients in the United States will have at least one episode, but 40 to 50% of those will go on to chronic disease.
Absolutely.
Of those, how many would actually fit into your category?
Yeah. So there's about 1 million spine fusions per year in America, So if you think about
That's
it
a
that way, the
lot.
way there is, but also having said what you said, it's probably a more limited percentage still out of that cohort, So it'd be a few percent of patients who are having chronic back issues. It certainly wouldn't be the majority. But this would be the worst group of people who are having back problems.
When you're looking at the proof of concept study
Yeah.
that you were involved in, what was the protocol look like for those particular patients that came into that study?
Yeah. So, and just to kind of close the loop on what you had asked earlier. So, in conventional spinal fusion surgery, what we do is we put in typically screws into the vertebra, then we remove the disc, we place a spacer to elevate the vertebra apart from each other, and then we use rods to realign the vertebra to each other. And then we use drills to remove the arthritic tissue that's pushing on the bones. So it sounds like a very comprehensive approach, right? The problem is that what we have found over the years, unfortunately, in studying all the patients out there who are having spine surgery, is that the outcomes of spine surgery are not as regular and consistent as the outcomes for other orthopedic surgeries. And the main reason for that is really the nerves. The nerves are unpredictable. They can develop scar tissue, and sometimes freeing the nerves is not enough to allow them to regenerate and to get better. So, in terms of our protocol, we were trying to focus on the patients that we thought were most likely to potentially have a bad outcome or a suboptimal outcome with conventional spine surgery. So, that would be people who've already had a back decompression. So, they've already had some degree of surgical alteration of the spine and have developed scar tissue as a result of the prior surgery. Or we wanted people where they had more than a year or 2 years of chronic nerve pain, very, very advanced high-grade compression of the nerves. Because what we know about people that if they have long-term neuropathic pain, which is a dysfunction of the nerve type of pain. So that's not just sharp pain, but it's a burning pain. It's hypersensitivity. It's more swelling and dysregulation of the tissues. These are all signs that the nerve is more severely and chronically injured. And those are the patients that by and large we know that don't do as well with conventional surgery. So those are the types of patients that our protocol tried to focus on in saying that, hey, can we develop this new procedure where in addition to the screws and rods, can we also put in electrical direct stimulation onto the nerves to essentially massage them with an electrical current and to provide a different modality to try to improve the nerve outcomes?
The nuts and bolts sounds a little bit like orthopedics, but we're dealing with
Yes.
the spine.
Yeah.
So a bit of carpentry there, but we're dealing with a lot of nerves. So there is a difference, a significant difference. There is many stimulators on the market, right?
Yeah.
So, and they've been around for a while. The great thing about the research that's being done and the global work that you and many others and the frontline research now is looking at non-opioid pain control. And
Absolutely.
I think from a first responder's perspective, it is amazing, right? Because the sooner we move away from opioid development, the better off it is, except for anesthetics. With all these different spinal cord stimulators, what is it that you're bringing to in your research that's different? I know that you're doing it and you're putting the stimulator in at the same time you're doing the bolts and the nuts and bolts.
Yeah.
Um, and but what's setting your research apart from what's being done already?
There's a couple of main types of stimulators that are on the market today. One would be spinal cord stimulation, where they would want to place leads into the middle of the back along the spinal cord with the ability to use then that electrical current to change the way that the body perceives pain signals. Another would be dorsal root ganglion or direct nerve stimulation, where the leads are placed kind of directly along individual smaller nerves that come out of the back. The challenge in general for spinal cord stimulation is just that the spinal cord itself is such an intensely, incredibly thick bundle of tissue that you are trying to deliver electrical stimulation to such a small or focused part within the spinal cord because for many of these patients it's not like their entire spinal cord has an issue, right? It's they have foot pain or they have knee pain or they have something, and so you're trying to in such a very specific way deliver this current to this area of the nervous system that's triggering some small area but the tissue itself, the bundle is so large, and there's a lot of tissues in the way, such as like the lining, the dura, the water of the spinal fluid, cerebrospinal fluid, those kinds of things. As far as the direct nerve stimulation, the way that's done right now, the dorsal root ganglion stimulation is typically through a percutaneous approach where under X-ray fluoroscopy, the lead is basically placed into the ligament that is near the nerve. And that tissue,
Okay.
yeah, that procedure is done by some proceduralists now. There are some technical difficulties in doing it, and that's probably one of the reasons why it's not more widely used today. But the other challenge is that because it has to stimulate through the ligamentous tissue, it requires quite a bit more current to get down to the nerve. What is totally unique about the way we did this procedure is that because we are doing it at the moment that we are actually physically, surgically removing all the tissue that's pushing on the nerves, it is literally a once in a lifetime opportunity where we have access to the nerves because we've just removed all the tissue that's pushing on them. In surgery, I can actually see the nerve directly. And so when we lay the nerve stimulator down on it, it's sitting actually physically on it. And what we found is that the levels at which we are of electrical current that we're able to stimulate and get paresthesias in the nerves is the lowest that's ever been shown.
In your device or devices, right? It's battery driven, right?
Yes, absolutely. Yep.
Yeah. So you insert a battery. How long does that battery potentially go for? Just for my listeners, because
Yeah,
when
absolutely.
everyone talks about a battery, they think about, oh, well, when is it going to run out? But
Yeah. Most of the spinal cord stim batteries and dorsal root ganglion batteries that are on the market today are kind of designed for the 5 to 10 year window, and that's initially what we had thought as well. We were shocked at how little current it was taking us to stimulate on the nerves just because of the way that we placed the leads directly on them. And so on our first several patients, we started kind of just doing some back of the napkin math and saying, well, if we're at this level of current and our battery has this much juice, how long is it going to take? And so, on these initial patients, our calculations were saying it may last like 120 years or something along those lines. So,
Okay.
I do think that, you know, what that allows us to do is actually to make the battery potentially very, very small and more comfortable. And so that's the sweet spot we want to hit is we want something that's going to last a long time, but to be very, very small.
One of the other things I was reading on your website is that the patient can actually dial up and dial down this particular sensitivity or stimulation. I was talking to this patient that also has a stimulation, and if they're going for a procedure and everything, they have to turn it off. And or if they're doing a change in the stimulation with this particular one she's got in her back, it takes a while for it to ramp back up because you've got a program that you've got to set it, reset it, and put it in. What's different with yours when it comes to patient comfort and suppression of the pain through your system?
Yeah, our battery talks to your phone through Bluetooth, and we try to empower the patients with quite a bit of personal ability to be able to modulate their symptoms. We do have team members that are available as well to help guide you and give you strategies in terms of the programming and whatnot. But we can control it in essentially real time. And so, that has been most valuable in patients who are recovering from surgery because as anyone who's had surgery knows, you have good days and you have bad days. And this is part of where we often get into trouble with the opioids is that right now, if you're having a really bad flare of pain after back surgery, one of the only tools that your surgeon has to be able to help you with that pain is narcotics. And one of the beauties of having the stimulator in, and particularly with having those real-time controls is now if you're having a bad day and a flare of severe nerve pain, several weeks after surgery, instead of potentially having to give you narcotics, we can just change the settings around on your stimulator, dial it up for a few days, try to get you over this flare, this attack, and then once things have settled down, return and change the settings back around.
So when are you going to publish your talk? You've got
Yes.
15 patients.
Yes.
You've done a few more, I've been
Yeah.
told. So I've done a bit of research into you over the last 48 hours.
Yeah.
Uh, but the patients need to know, and people like
Absolutely.
myself would like to research
Yeah.
and know more.
We have presented our data at some national meetings, so predominantly for
Yeah.
other doctors and specialists.
Okay.
But yeah, the manuscript is currently under submission right now, so
Okay.
we are excited for that to be coming out shortly.
So it's good. I'll be looking forward to reading about that.
Absolutely.
And thank you very much for that. And you're moving on into a randomized phase 3 trial.
Yeah.
So two questions here on the trial. One is, again, is the protocol going to be the similar sort of patient? And the second question I have is, and this was brought up with this patient that I was talking to yesterday, is that if this is so good and you've previously had a spinal cord stimulator system put into your back, is there a way that if the trial shows significant results, would you be able to change over to e-TLIF, Cinefuse or another agent, another spinal system stimulator, if you previously had one before?
Yeah. John, one of the challenges with the FDA is things have to go so step by step. So the first clinical
Yeah.
trial was really focused around safety more than anything. These were two technologies that had never been combined, and the FDA just wanted to make sure that nothing funny happened. And so thankfully, we were able to get that part done and sort of prove that there were no adverse effects and that it worked fine. The next clinical trial for us will be designed towards scaling and trying to prove efficacy. And so the plan is for a randomized controlled trial where some patients are just going to have normal back fusions and some patients are going to have the e-TLIF procedure with insertion of the direct nerve stimulation. And we want those patient populations to be essentially identical, and so we can really just directly with the same surgeon, same hands, say we've got these two techniques and look at the difference, and we have an idea of what that will look like just based on our preliminary data versus what standard of care surgical outcomes have been out there. But it's obviously most powerful to be able to do it in a prospective randomized trial, 20 hospitals around the country, numerous surgeons and new patients who are coming into this. The FDA did have a lot of concerns about side effects and cross reactions with other stimulators. And so on the initial study, it was actually an exclusion criteria,
That's good.
unfortunately.
Yeah.
And I don't actually suspect that it would be long-term. I don't know why it would be. I'm certainly less concerned about a cross reaction there, but I think that that's something that in a delayed setting, we will have to kind of backtrack and do as a separate trial and just kind of prove that there's not that issue there to try to get that exclusion criteria removed in the future.
You think that down the line, if you've had a previously stimulator put into your back, you may be able to cross over to e-TLIF?
I would hope so for sure, but that is something that we will have to overcome, with the regulatory level.
And probably at a clinical trial level as well.
Exactly. Yeah.
So just on your trial now that you're doing, I've heard a lot of good comments about the pain relief, even from this patient. She said the pain relief is amazing with the spinal cord stimulator system. She has virtually control of her pain all the time. There are times where it does flare up for whatever reason. She can turn up the volume, as one would say, and for 2 to 3 days, and it seems to control it and turn it down. And minimally taking anti-inflammatories for this, and she's also on
Neurontin potentially.
Gonna say Neurontin, but I was trying to keep away from brand names. But Neurontin.
Gabapentin.
Yeah, thank you. To also control the pain as well. It's a major change for patients. You've mentioned the good things. What's some of the adverse events that can occur from e-TLIF?
Well, you would have the normal risk profile of surgery, right? And so, that could be standard complications such as an infection or bleeding. Anytime you're putting hardware into the back, you need the hardware to take correctly and the fusion to happen correctly. So if you had a challenge there, with screws loosening or a spacer not taking through, that can lead to future issues. One of the things we were looking at closely in the clinical trial was our method of securing the lead strong enough or would leads move in the future, have what you call lead migration. So those were a lot of the things that we were concerned about. And we were pretty pleasantly really pleased with the outcomes as they came through in the clinical trial. And we have taken some steps as a company to even augment some of that. And so we've developed new anchors that are very specifically designed to be able to fixate the way that the lead would sit and be connected to the rod so it won't move out of its position. So these are things that we're trying to take active steps on our end to really be proactive and to optimize the procedure and to limit it as much as possible to sort of standard or routine surgical risk.
Would patients with osteoporosis be excluded, or how does that fit into the spinal
Yeah,
process? Because
same thing.
they get compression.
Right, exactly. For the first clinical trials and whatnot, it is an exclusion criteria. There are people out there with osteoporosis who end up having back fusions at times. Certainly, it's very risky cases. And in many of those cases, you'd want to start with a DMARD or, one of those bone strengthening medications such as, teriparatide or whatnot,
Yeah.
and and use those to strengthen the bone for a while before going in and doing a fusion operation. And I think ultimately, if we are able to get regulatory approval to do these cases on patients with osteoporosis, we would have a lot of those same protocols for strengthening the bone. Ultimately, though, big picture, we are excited and interested that electricity is a great way to form bones and to strengthen bones. A lot of the products and things that are out there today to help augment fusion are external bone stimulators. And so what it is a lot of times is someone after a back fusion surgery, they may wear a vest, which is essentially delivering electrical impulses into the spine. So it's not something where we're making claims right now about the stimulator and the ability to improve the ability of the bones to fuse to each other, but it's certainly something we're cognizant of. And we're curious going forward as to, is there a way that we can also use these electrical leads and our technology to help with that?
With your e-TLF procedure, did you have to develop a specific lead? Is it a unique lead to your procedure that you're doing it when the whole operation is open and the nerve is actually exposed? Is your leads different to other leads?
Yeah. So the first clinical trial we performed was with sort of a stock product that is sort of on the shelf today. But as we are looking at the next trial and ultimately going commercial, we do have a new complete device with custom leads, custom anchors, all of that we've designed ourselves.
So one of the other questions that this patient did talk about, you have your different scans and you have MRI.
Yeah.
So does MRI impact upon the insertion of a electrostimulator?
No, our hardware is MRI compatible, and actually, we've at times gotten MRIs on patients who've had the surgery afterwards, and there were no issues. So actually, even the artifact was very manageable.
What I was reading is that sometimes the MRI you can get distortion.
Definitely, yeah. So, and for a lot of the older technologies, whether it's stimulators or even screws and rods, it used to be very, very bad in terms of the MRI distortion. That is something the field has come a very long ways in being able to manage, and so
Okay.
most of the new stuff coming out is pretty MRI compatible these days.
Okay. The other big area that you're talking about is neuromodulation.
Yeah, for sure. Yeah. So
That's one of your pet likes or research.
Some of our team, we've got members of our team that sort of go on both sides of it. In many ways, I would say my day-to-day practice is more focused on robotic and minimally invasive spine surgery, so more of decompressing and fixing the spine. Dr. Michael Park, who is our chief technology officer and a functional neurosurgeon at the University of Minnesota, he really specializes very, very much in neuromodulation. And we have members of our medical advisory board, such as Dr. Stephen Falowski, Dr. Namir Haider, who are also specialists very much in neuromodulation. But yeah, neuromodulation is ultimately a very fast growing and important part of spine surgery and spine care. And the fundamental idea behind it is what's called the gated theory of pain. And so it says that basically nerves are often only able to feel one thing at one time and feel one thing in one location. So part of that is, for example, many patients will describe that what they call migrating pain. And it can be odd that like, my left ankle hurts and then my right knee hurts and then my hip hurts, but never all at the same time, and why is that? Well, a lot of that has to do with your brain actually, right? So, cause you may be having signals all the time, but your brain is kind of deciding what does it want to focus in on and what does it want to tune out. And the nerves are typically only able to send signals at one time of either sensation, saying, I'm feeling something touching me, or else I'm feeling pain. That's one, idea behind massage and a lot of other just physical
Mm.
medicine modalities is if we are touching and pushing on an area, we're creating more of that stimulus for the nerve and the nerve may sort of tune out that pain stimulus that's going on there. And so the idea of neuromodulation is that can we sort of, I don't know if trick the word is the right technology, but or the right terminology, but can we, but through electrical stimulation, convince the nerve, hey, I'm being massaged, I'm being touched, something else is happening here, and convince it to not convey those pain signals. And so that's what spinal cord stimulation, direct nerve stimulation, a lot of these technologies are doing.
In my time when developing non-steroidal anti-inflammatories, it was cyclic. Pain was always cyclic. Is this
Yeah.
actually snapping or breaking the cycle? Is that a simple way of?
It is. It's a way of the gate is blocking the pain signals from coming through, but that also has better downstream effects that we know that, the more that the brain feels a high degree pain for a longer period of time, that can have really deleterious downstream effects, in terms of mental health, different things. And so, that's one thing that we found with spinal cord stimulators and neuromodulation techniques is they can improve rates of depression, mental health, disability, all these different things, just because the patient is not in as consistent, severe chronic pain. And so we do think that bringing that element of our technology in for the e-TLIF procedure is one of the important benefits.
An area that you've spoken very, very passionately about is robotics and AI.
Yeah.
Um, and this is going gangbusters in other surgery, colorectal surgery, liver transplants, but it's also going gangbusters and setting a whole new paradigm in spinal surgery. This is where the future is, the new look for spinal surgery. And you're in
It's
your hands, you're a major
yeah.
researcher
Yeah, yeah,
globally
yeah.
for this.
I cannot, John, tell you how fast it's moving. It's absolutely unbelievable. I mean, 10 years ago, it was a garden trinket that essentially any surgeon who used it would tell you only slowed them down and didn't really help in any surgery other than just hypothetically being cool. I, started doing these surgeries, several, 6, 7 years ago. And even for me in the beginning, it was something that I was passionate about implementing and I wanted to be on the front end of it. But, I would say my first year or two, it would be a little bit difficult to have a lot of perspective on how it was helping me. And the robots has gotten so much better every year, every iteration, and as we're developing the ones, and now thankfully I'm involved in the design of a lot of these, and so I'm seeing the ones that are going to come out in 2 or 3 years, and it is absolutely mind blowing. And so, the robot has a lot of fundamental advantages that the human doesn't have. It is able to see through tissues in a way that we can't see through, So, whereas for me, a lot of times, if I wanna know where a bone is, I need to be able to physically touch it, look at it, use my senses. The robot has completely different ways to be able to react to it, interpret image guidance, move to the correct position. That allows us to be much more minimally invasive with our surgeries, more precise with our surgeries, and, place hardware and move things around in more perfect ways. Beyond that, a lot of the new adjuncts that are coming out in robotics are gonna be really special in terms of even their ability to do really impressive things like drill, realign the spine, place hardware, and really help the human surgeons a lot. And AI is moving fast on this too, where AI will increasingly be able to look at someone's back and a problem and create kind of an optimized algorithm for what the ideal solution and way to fix it is.
I was just reading this morning from Elon Musk is that medical education will be a thing of the past because AI will take it over. How does that feeling work with you? I mean, we're talking about robotics going in and doing things that the normal surgeon can't do. How does the surgeon fit into this
Yeah.
process?
Right.
But the AI is making such a big difference.
Yeah. I do think that I think I saw that interview as well, and
Yeah.
there were elements of it, and there always are with these that might be on the edge of sensational. It's certainly in 3 years. I don't think you're going to not have a surgeon. So yeah, I think that the more practical way that I look at it is how can this technology in 3 years really help your surgeon do a better job? As far as robotics and medicine in general goes, I mean, there's so much there that might be potentially pretty low-hanging fruit that could make medicine a lot better. And a lot of times I look at the hospital and I say, so much of what we do in the hospital or our own protocols are so primitive that let's
Mm.
focus on fixing some of that stuff first. I mean, patients are still lying in bed with a call light. I mean, it's completely crazy if you think about it, right? I mean, why doesn't every patient have a personalized, chat bot or AI assistant that they can say like, hey, my left ankle hurts, can I have pain medicine? Can you alert the doctor? Just some degree of organization. How
True.
can we use robotics to help nurses be more efficient? A lot of times nurses, still to this day can have 6, 7 patients at a time, be extremely
Yeah.
overwhelmed. I think that there's so many ways that robotics can in even lower stakes than, saying like, hi, John, here's your surgeon, and you're just looking at a robot. I think that most of us would really struggle with that.
I would
you know?
freak out to tell
Yeah,
you the
yeah,
truth.
yeah. So, I think that,
Yeah.
for the foreseeable future, even if the robot is helping the surgeon tremendously and doing more and more of some of the logistical things on its own, having the surgeon as a safeguard and as a subject matter expert and someone who can, educate patients and help to develop the plan and really help to execute the plan. I don't think that's really going anywhere anytime soon. But there's a lot of really, maybe low-hanging fruit, like in the hospital, just in how do we deliver medicines? How do we communicate what a patient has going on? Yeah, and even basic things like, can we just get other health systems to like send your scans and images over and, these kinds of
Yeah.
really basic things.
Less errors too, by the way, and quicker
Exactly.
recovery, right?
Yeah,
So
yeah, yeah, yeah. So
that's what it's really about. It's, there's less trauma to the muscles, bones, etc., and that allows for better pain control and quicker. Last thing, right? We've talked a lot about the trials, about Cinefuse. What's your summary? What's your 3 key takeaways for anyone that's out there listening to this that's got this degenerated disease, and or they know people that have got significant spinal pain? What's your takeaway?
yeah. I think that if you have long-term really nerve pain and neuropathic pain and your imaging and your problems in your spine are so advanced to where you may be looking at surgery, I think it's important to look at some of these newest technologies such as the e-TLIF procedure that may be incorporating neuromodulation in addition to surgically fixating the spine, because that may have a better chance for a better outcome. And thing I would just say is that, I do think overall the field of medicine and in spine surgery is moving fast. And so that's one piece of good news, that I don't believe that a lot of the surgeries that we do right now are going to be done the same way in 5 to 7 years. And so my hope is that this can radically improve patient outcomes and hopefully sooner than later. And beyond that, then, we talked about early on just how common these back issues and this degeneration and even disabling levels of it can be out there. And in many ways, right now, the reason that we only offer surgery to patients who are at such dire straits or basically functionally disabled is that the surgery is so major and frankly so risky in some ways that if you're not in really bad shape, we got to think 2-3 times about should we even take the risks of surgery and the recovery and everything that goes with it. And one of the things that's an important frontier for spine surgery is how can we get the outcomes so good, the risks so low, and the procedures more minimally invasive to where we can get to a point where we can just offer those services to more people, where we don't have to wait until it is a really desperate state of affairs before saying, okay, now that you're, unable to walk to the mailbox, now you're a candidate for back surgery. Because there's a lot of patients in the middle who are limited and would
Yes.
like to be able to work better, do things better, run and have these quality of life things. But we need interventions that are safe enough, that help them enough that they can get an improvement in their quality of life too.
That's fantastic. I would like to interview you when you get your phase 3 set up.
Yes.
We could talk about the phase 3 and the protocol and, you know, how you're going to, you've got 20 centers, and the centers involved in that will be obviously, from what you've discussed today, a real asset for patients that are suffering from pain. And I know you've said this before, this is a highly specialized technique where you need a multidisciplinary team and you need a surgeon, a neurosurgeon that's doing these things every day. So there should be only a few centers that have those capabilities. Would robotics be included in that randomized phase 3 trial?
Yeah, right now we want to leave robotics open to both sides of the arms because we don't want
Okay.
that to overly sway it one way or the other. So that will be randomized. But we are considering closely at all of our company development intervals, how are we incorporating robotics and maximizing it?
All right. Well, thank you very much, Dr. Lall. I really appreciate your time today. And on behalf of those listeners, just can't thank you enough, and congratulations on all the research that you are doing at Fairview Health. It's amazing, fantastic, and we're looking forward to having you back on MedInsights Unleashed in the future. Really appreciate it.
Thanks for having me.
MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.